This is regarding what is in most countries would just be referred to as national health insurance. In the United States, the physicians movement has referred to it as single payer very often. It's also what's known in political sphere as Medicare for all, which is a terrible term. Should be expanded and improved Medicare for all, which is also what we've referred to it in the past. Here in New York, your physician colleagues like myself are with the local chapter, Physicians for National Health Program. And because New York State is actually the state that is furthest along to possibly actually enacting this, I mentioned the New York Health Campaign, or the Campaign for New York Health, which is the volunteers that are promoting this in New York State. So I have no financial relationships with any commercial interests. I am on the board of directors and the executive committee of P&HP New York Metro Chapter, a not-for-profit education advocacy organization. Not only do I not receive any compensation, but as a board member, it costs me money. This is an outline of the slides of what we'll be covering, the background of how we got here. So basically where we are today is we have both uninsured persons, but also many more underinsured persons who may nominally have insurance but don't have good access to care for a variety of reasons that we'll talk about. An aging population, increasing overall economic inequality, and we also have a fair amount of maldistribution. So in some places there are too many hospitals and too many doctors and even arguably overcare, but there are also many places where we have too few and too little, and it discriminates and is inequitable on the basis, the usual bases, as they are in the United States, of race, gender, age, income, wealth, employment status, and so forth. I would suggest that there is an inherent perversity of incentives in the way health care overall works and health insurance works. And when I say inherent, I mean it's inherent to the system. I mean, there was an economist back in the 60s, Ken Arrow, the leading health economist of his day, who sort of figured out that simple supply and demand just doesn't work. We have gaps in coverage due to churn and complexity of the healthcare system, fragmented care and coverage, and an increase in bureaucracy of the for-profit sector, which is making life miserable for both doctors and patients alike, and it's completely unaccountable, except to Wall Street and lobbyists. So let's go back to first principles. What is the purpose of insurance? Any insurance, health insurance just being one example. So going back to Lloyd's of London, insuring the first commercial ships, and actually the Dutch, with the Dutch East Indies, going back to the first European imperialist trading, the purpose of insurance is to spread the risk. It's to create an insurance pool so that everybody in the pool is paying in a little amount all the time, because there's going to be rare, big events that you can't pay for out of pocket. So if it's your entire ship sinking in the ocean, sinking at sea, with all of the wealth and capital involved in that, or if it's you having a heart attack and needing to go into the hospital, it's relatively rarer events that nobody can afford to pay for at the point of service out of pocket, being covered by an insurance pool. That's the entire theoretical underlying purpose of insurance. And that's why one of our slogans of everybody in, nobody out, suggesting that the most natural and efficient pool for the United States is everybody in the United States in one insurance pool, isn't just a slogan, it's actually an economic necessity to make this work. If you contrast that by what is the business of the for-profit corporate health insurance industry, their business is to create an investment pool for Wall Street. That is their legal fiduciary responsibility. An actual provision of health care, the insurance pool for providing health care, is actually what in supermarket terms is called their loss leader. It's what gets you in to give them the money, but it's not their actual underlying purpose. And they actually refer to health care as the medical loss ratio, which pretty much tells you everything you need. They compete only by selecting for that part of the pool, which is either less sick or more wealthy. So they select for the healthy and the wealthy, and they dump the sicker folks and the lower income folks back into the public pool of public Medicare and Medicaid. And we've known this, as I said, since Ken Arrow did some work for which he won the Nobel Prize in the early 60s, um, that if you ever hear anybody talk about supply and demand, simple supply and demand in healthcare economics, you know that either they're lying or they don't know what they're talking about. There is no health economist, including those on the conservative end of the spectrum, that will think that simplistic supply and demand works. The general public, if you think of them as the consumer, the patient, either before they get sick or after they get sick, has no ability to negotiate or price shop. Prices for healthcare, let's say coming into the hospital, are both fixed and not transparent. And when you have a heart attack, you can't say, ooh, am I going to go to the Brooklyn hospital or maybe I'll go to Brookdale because that's closer? No, you don't. You're having a heart attack. You don't have a choice. You have basically, even for outpatient primary care, the choice of who is in your network and how close and what the time is to get there. There's really no ability for the general public before or after they get sick to negotiate. There's a complex three-way dance going on between patients, the doctors and hospitals as the provider of care, and the insurance companies as the payer for care. The doctors and hospitals can to some extent drive demand, and the payers can to some extent slow demand. Those are all inherent problems. So how did we get where we are today? Well, the short answer is the United States is uniquely weird. We basically had the rise before World War II, there was very little health insurance out there. With World War II, we had the rise of private, for-profit, employer-based health insurance based on negotiations between workers and their employers. And this came in because during World War II, we had both the rise of the union movement coming out of the Great Depression and FDR and so forth. But we also had World War II, which imposed wage freezes. And so labor and employers were left to negotiate for benefits only. In the 1960s, so if you think of who gets insurance under private, for-profit group health insurance through your employer, you realize who's not covered. Well, number one, the elderly who are retired persons, or the chronically disabled who are not able to be employed. And so we bring in Medicare to cover them, as well as very, very poor persons, additionally the so-called quote unquote deserving poor, which meant single women with children who were not in the employment market and they were eligible for Medicaid. We then had the expansion with the ACA, which basically did two things. And the big thing it did is expanded Medicaid eligibility so that you did not have to have other requirements such as having dependent children in the household. So if you were very, very poor and single and didn't have kids, you were not eligible for Medicaid in most states. ACA changed that. It also raised the threshold level of poverty for being eligible to a certain extent. The other thing that the ACA did is it said, well, if you don't have access to a group health insurance plan through your provider, we will provide you access to a group health insurance plan through the fact that you are a resident of a state. So if you're in New York State and you don't have health insurance otherwise, you can purchase group health insurance on the New York State Exchange. It is still private for-profit health insurance. You're still buying from Aetna or United or Emblem or what have you. It is not the same as having public insurance through Medicare, Part A or B or Medicaid. It simply means you have access to a group health insurance as opposed to solo health insurance, meaning you would be in your own insurance pool, which is basically unaffordable. So those were the two expansions that Medicare did. We have a continued fight with the more conservative elements, noted here in red for some reason, who want to continue to attack the ACA, cut Medicare and Medicaid, and increasingly privatize. based on sort of a free market fundamentalist philosophy that privatizing is inherently good, although back channel having to provide a fair amount of public money to subsidize the private for-profit insurance companies. I should mention the ACA does the same. That's what the premium supports, that allows sort of lower working class, not eligible for Medicaid, but can't afford a full price of the premiums out of pocket, even on the exchange. The so-called premium support is taxpayer money going to the private insurance companies to subsidize guaranteed profits. We have the Democratic Party with continued tinkering with incremental changes to the existing system, and then we have the idea of single payer, reinvigorated in particular in the 2016 Democratic Party primaries, but frankly existing for many years before that. What is single payer, aka expanded and improved Medicare for all national health insurance? It is publicly funded, privately delivered. Let me repeat that. Publicly funded, privately delivered national health insurance. It's the financing, not the delivery. The current system under single payer, the current system of mostly private delivery of healthcare, private hospitals, private doctors' offices, some public, some for profit, some not for profit on the doctor's side, would continue to exist. It would not be a national health service such as the United Kingdom has, or which is modeled for in the United States by things like the Veterans Administration and the Department of Defense, with military, federally government employed physicians, federally government run hospitals and clinics. It is not that. The publicly funding would replace what in effect is a flat tax of premiums, copays, and deductibles, plus all the out-of-pocket expenses that folks run into, with a progressive tax such that, depending on the details of the plan, between 92 and 98% of persons would pay less, as well as all of the current employers that are current contributors to the current system would also be paying less. All the providers would take, if they take any insurance, this would be the only insurance they would take. And all the patients would be automatically eligible. All of the plans cover full range of medical, dental, dental health, mental health, full range of medical and surgical care, outpatient, inpatient, specialty, etc. It also covers, and this is very important with the growing aging population, comprehensive long-term care. That's both home health care and, where necessary, nursing home care, as well as copays, no copays for drugs in the pure form. The Sanders bill has, I think, a small copay. No copays for drugs, full comprehensive hearing, vision, and medical supplies. Everybody has it. Freedom of choice for patients. We like to use freedom as a buzzword, so this would be freedom of choice for patients of all hospitals and doctors and other healthcare providers provide it. The bugaboo is, oh, it takes away your choice. Well, it takes away your choice of having one private insurance company or another private insurance company if you can afford them. It does provide the increased no networks. All the doctors and hospitals take it, and you always have it. It provides security. You always have it, regardless of changes in your employment status or other life circumstances. As I mentioned before, as we'll see later, incentives for-profit private insurance are inherently perverse. The fragmented pool, it causes a race to the bottom from the insurance company's perspective. And the only way, from a simple economics health policy point of view, and even conservative groups have acknowledged this, if your goal is to cover everybody and reduce total system costs and reduce costs to the vast majority of individuals, families, and businesses and employers, then single pay is the way to go. That's the economic argument. The moral argument is, do we treat access to health care, or at least health care coverage, as a for-profit private commodity to be purchased? In other words, your widget du jour, do I get an iPhone or a Samsung? Or is it a social and communal need? And we sometimes make an analogy to the fire department. You've prepaid for the fire department with your taxes. It's just always there in case you need it. and if you have a fire, the firemen come and put it out. They don't ask you if you're in their network. They don't ask you for a copay or deductible ahead of time before they start putting the fire out. They come and put the fire out. So, a couple of problems. We have the remaining uninsured. Basically, we went from slightly over 52 million uninsured in the United States to roughly half that, in the range of 25 to 30 million uninsured after the ACA. So that is indeed a great change, and I do not knock it. In fact, I was fighting against repeal and replace back in 2017 when that was being proposed. It is, we said it was immoral to take away health insurance from 25 million people who just gotten it. We also suggest it's immoral that there are still 25 million people still uninsured. And of course, that bounces around depending on when you've got recessions due to things like the COVID pandemic. I think it says something that when the COVID pandemic hit, all of the things we wanted to do, like vaccination and even care initially and screening for COVID, all of a sudden the suggestion was, let's make the government cover that without cost. Well, yeah, we should just do that for everything, like every other developed country in the world. So who are the remaining uninsured? Well, it turns out that there is nationally, there's a bit of a misconception on who that is. Nationwide, the majority of the uninsured are not, I repeat, not undocumented immigrants. This is a false narrative that is out there. Now, I will say in New York State, because of a relatively good expansion of Medicaid and a relatively good exchange plan, the numbers are different state by state, but nationwide, July 2018 analysis done by the Urban Institute, which is not a group that supports single payer, by the way, pre-COVID, but full roll-in of the ACA in terms of the timing of when this was, shows that in fact 25% of the folks who will remain uninsured are eligible for subsidies, but are still not enrolled. They just haven't they're either caught in between the churn of the system, off one plan, on not yet onto another plan, or they just are too damn complicated for them to deal with getting through the enrollment hoops that we have, or despite the fact that they're eligible for subsidies, they feel it's too expensive. Another 25% are eligible for Medicaid in the state in which they are, per their state rules, but are still not enrolled. Again, the complexity of getting enrolled, the barriers to getting enrolled, the fact that it's not automatic. An additional 15% ineligible for the subsidies despite their income being too high for getting the subsidies, but they still aren't enrolled because they either, again, complexity of jumping through the hoops to get enrolled, or they feel it's too expensive. 9% not eligible because in principle they're covered under their employer's plan, but they're not in fact enrolled in their employer's plan. 16% ineligible due to the immigration status. That's the one that some people believe falsely is the majority. It is not even close to that. It's not even close to being a plurality. And only 9% are actually ineligible for Medicaid because their state is not expanded. So the those states which fail to expand Medicaid under the ACA Medicaid expansion, the remaining completely uninsured amounts to 9%. I would suggest that as bad as the uninsured, completely uninsured is, the bigger system-wide problem that we continue to have is underinsured and, forgive my French, too damn expensive. This shows in the dark blue and light blue, respectively, the overall inflation rate and the rise in workers' earnings over time, and in the orange and yellow, the rise in the cost of premiums for a family plan under employment-based health insurance, as well as even greater than that, the worker contribution, the amount that the worker is paying as opposed to the employer is paying for that plan. And as you can see, both family premiums and worker contributions are rising. The costs are rising far greater than wages or inflation. So premium costs are going up far faster than background inflation rates. And that's despite supposedly the ACA was supposed to bend that curve. It did not. Deductibles are rising even more than premiums. So again, you see overall inflation and workers' earnings at the bottom in the dark blue. You see the rise in the premiums which are double that. And then you see the rise in deductibles, the amount of that people have to pay out of pocket, having paid the premium, the amount they still have to pay out of pocket before the insurance kicks in. And that's triple that. And again, has not been deflected by the ACA. So out-of-pocket costs, both premiums, deductibles, and copays, continue to accelerate as a direct point-of-service cost for anybody seeking healthcare far faster than background inflation rates or income. We see that underinsurance, and there's a systematic measure that's being used here, again, by the Commonwealth Fund Health Insurance Survey over many years. The key thing here is they're using the same measure from year to year. Out-of-pocket costs greater than 10% of income. As you see on the bottom, there's the definitions. And again, the point is it has more than doubled since 2003, and it has continued to increase despite the ACA. And I should update this slide, and I will do so before my next talk, given this is from 2016. So that's the issue of cost, even if you have insurance, going up, up, up. The other problem with nominally having insurance, in addition to the fact that it's still too damn expensive to get health care when you get sick, and too damn expensive to keep paying the premiums on a monthly basis, even when you're not sick, is you may have insurance, but that may not give you access to care. For example, I am proud as a pediatrician that 2 out of 3 general pediatricians, in fact, take Medicaid. But overall, that's not true. And here we see pediatric specialists not taking Medicaid. So you nominally are insured if you have Medicaid, but if the overwhelming majority of physicians don't take Medicaid, your nominal insurance doesn't amount to a hill of beans, and you still don't have access to health care. Healthcare costs are remaining, despite the ACA, the leading cause of personal bankruptcy. This remained true despite things like people losing their homes due to mortgage financing during the Great Recession, and remains true despite the ACA. There are serial studies on this, at least through 2019. 2 out of 3 persons filing for personal bankruptcy attributed healthcare costs as the major factor, and 3 out of 4 of them had health insurance at the point that they became ill and still went bankrupt. So having nominal health insurance didn't keep them from going bankrupt when they got sick. Some of that is they got sick. They therefore, because they were sick, lost their jobs. Therefore, they lost their health insurance just when they needed it. And some of it was also those out-of-pocket costs. Medical bills are the most common reason for collection calls. In fact, almost 60% of all collection calls are for medical bills, with all other reasons being around 40%. And the most common cause in the United States for personal GoFundMes. Medical bankruptcy does not exist as an entity in the rest of the developed, industrialized, capitalist, democratic world. Whether you're talking Western Europe or Taiwan or South Korea or Japan or Australia, this is a made in America only problem. So we like to say that the problem with underinsurance is a little bit like a hospital gown. You may have it, but the chances are your behind, shall we say, still isn't covered. You're still going to have those problems. So let's talk about what we have with private health insurance. It is inherently less efficient than public insurance. I am not saying that this is true for everything in the universe, but in terms of capitalism versus communal public good, but it is true for the reasons I've outlined previously, that you need to have a single large pool for efficiency. The people who are immediately sick or poor do also need coverage, and the healthy and wealthy have to pay in all the time to make the whole thing work. First of all, private insurance costs continue to rise faster than public insurance. So the costs of private insurance, shown here in the orange, have continued to accelerate on a per capita, per enrollee basis faster than Medicare or Medicaid, accelerating away from where they're zeroed down in 2009. The overhead, the administrative overhead of private insurance continues to be far more than Medicare. Medicare's If anything, probably a little bit too low at 2%. But the private insurance companies, despite nominally being capped at 15% under the ACA, have continued even in their public reportings to be greater than that. And there's a variety of ways in which they hide some of the administrative and profit making above this. But as you can see, every additional, 98% of Medicare monies is going to healthcare. Less than 85% is going to healthcare with private insurance. Inherently less efficient. The insurance overhead, just the cost of administrating and having the insurance on the insurer's side, is roughly 5 times the cost in the United States compared to what it is in other countries, the other developed capitalist democracies around the world. We're talking roughly 5 or more times the cost per capita to administer the insurance. Again, combination of for-profit, multi-payer with hundreds of different plans out there, having high administrative costs and fragmentation of coverage. One example on the delivery side of this, so that was the insurance company. Now let's talk about the cost of insurance, but for the delivery side. So for hospitals, here's an interesting example. Duke Medical Center, 3 separate hospitals near each other, making up Duke Medical Center, 957 beds, and they have 1,600 billing clerks. Think about that for a moment. 1,600 billing clerks for 957 beds. The University of Toronto Medical Center, Academic Medical Center in Canada, 456 beds, 3 billing clerks, essentially 1 for Ontario, 1 for the rest of Canada, and 1 for the rest of the world. The Cleveland Clinic has to maintain 210 million prices in their billing computer system. Why? Well, they have 3,000 different plans with over 70,000 different procedures and diagnostic codes and billing codes. As a place that draws nationally, if not internationally even, they may be amongst the worst in terms of having that many different contracted plans. This is insane. This is just ridiculous. And so it results, again, as you can see, on the hospital billing and administrative cost per capita, not the insurance side that we already spoke about, but on the provider side, in this case, the hospitals, roughly 5 times the cost in the United States compared to Canada. Similarly, physician office billing, again, the administrative costs of billing the insurance companies and then having to bill them again, and they deny it and they reduce it, and you try to get some of the money from the patient and some of the money again from the insurance company over and over and over again, 5 times the cost in the United States compared to Canada. What we've seen is a massive growth in healthcare administration compared to healthcare in the United States over time. This shows from the Federal Bureau of Labor Statistics in the ACWA, the rise in people employed in healthcare management, compared to in the yellow, the much smaller rise as a percent increase in the number of physicians. And any of your old-timer physicians, myself included, in my case, even just since the late 80s, I can tell you there has been this massive increase in the layers and layers and layers of overhead of management. And guess what? It does not save money. It just takes more money out of the system for everything but healthcare. What about drugs? We sometimes hear the claim that, the drug companies need to be paid the full amount of what they are, and if you reduce the amount that they're going to be paid, that somehow or other they're not going to be able to provide us with new drugs or even our current drugs because they have to have the money for research and innovation. The short word for that is it's completely false, and it's obviously false if you think about it for a moment. First of all, we pay on average about 2.5 times the price per capita spending on prescription drugs than do the, again, rest of the developed capitalist industrialized democracies around the world. um, in terms of the per capita spending on prescription drugs. Where are the drug companies' cost structure? Well, in fact, they pay very little, according to their own public filings. They pay very little on a research and development, which captures a lot of things, as you might imagine, that you and I, as potential scientists, wouldn't necessarily really consider research. But even in their broad definition of research and development, it's only 13%. And let's remember that the overwhelming amount of primary basic science research and even second level research is publicly funded. We have the National Institutes for Health. Um, Europe has similar ones. I'm sure Germany does too. I'm familiar with the United Kingdom and Germany having public funding for research with the COVID vaccine development that's occurred around Pfizer, Genentech, and AstraZeneca, for examples. Again, publicly funded research is the overwhelming amount of funding for basic science research that gets turned into drugs and vaccines and biologics, and even much of the secondary level of development. And that's true across, again, other countries as well. So let's remember these are all multinational, might even say transnational drug companies selling the same drugs, same companies selling the same drugs across Western Europe, Japan, Taiwan, South Korea, Australia, New Zealand. So if you compare the return on revenue of the pharmaceutical industry for drug companies compared to the Fortune 500 median, you will see that the return on revenue for the drug company sector, the pharmaceutical sector, is double that of the Fortune 500 average. Year in and year out, double. What is going on here is the drug companies make a perfectly fine Fortune 500 average profit in France and Germany and Taiwan and South Korea and New Zealand and Denmark and the United Kingdom, etc. And they make excess profit in the United States. Those other countries are able to negotiate at the national level lower drug prices, again, same drugs, same drug companies, and there's excess profit making not going to research by the drug companies in the United States, whereas we've seen in the most recent political fight inability to control costs, to inability of our federal government to agree to negotiate prices because of corporate lobbying. I should mention there's a specific bill way back when I was in college called the Bayh-Dole Act, which blocked the NIH from profit sharing in patents that came from publicly funded research. So the NIH gives taxpayer funded grants to universities and companies to do research, and when they come up with something where the capital for the research was public taxpayer money through NIH grants, the university and the private companies are allowed to patent it, and the intellectual property is by law not allowed to be shared by the public, even though we paid for it. It doesn't have to be this way. United States, in terms of overall spending, and I do promise to come to why this is good for doctors as well, but in terms of the overall system and patients, it doesn't have to be this way. First of all, the United States, with our privatized and fragmented payer system, has increasing costs relative to other countries. We are already paying 2/3 of our healthcare spending already coming from our taxes, whether it's Medicare, 20%, Medicaid, 17%, the tax subsidies that I mentioned before that go in a variety of ways as tax subsidies to private insurance, covering some of the premium costs of private insurance. Plus, government workers have as their employer, you as a taxpayer, government workers have their benefits package, including insurance and their retirement benefits. And of course, there is some VA and other public, like health and hospitals, your Kings counties, your SUNY downstates for that matter, Bellevue, and so forth. So the U.S. already is paying in taxpayers' money more than the average of other countries, and in addition, because our system is so excessively expensive, we're paying even more above that, as shown in this slide. There's an interesting natural experiment. Um, Canada is really, in many ways, the country that's closest to us. Lots of immigration, um, license across the U.S. to Canada. Doctors can actually move relatively easier there than anywhere else. Similarly, in terms of their medical school and residency program, is most similar to us. And what we see here is the GDP per spending up until the early 70s was about the same and growing at about the same rate. In the early 70s, Canada finished implementing across all of their provinces their public, universal public insurance system on the one hand, and in the United States, something called the HMO Act passed, Health Maintenance Organization Act, passed towards the end of the Nixon administration. Um, that set off a bunch of things. One of the things that was in the HMO Act was allowing increased for-profit privatization. So certain things were not even allowed in terms of for-profit. You didn't have for-profit hospitals, and you didn't have all of the Blue Cross Blue Shield actually having been converted to for-profit insurance companies. All of that happened with the HMO Act. And what you have is, starting at that sort of natural experiment with two changes in the systems in the US and Canada, what you see is an acceleration of the difference in the amount of spending per capita uh, in the United States compared to Canada. What about outcomes? Well, we've had a worsening outcome since then. So already, at the time of that, in the late 70s, which is where the data I have goes back to, the United States had one less year per life. So Canada had one greater life expectancy. The gap was 1 year. Over time, that has now increased to 3 years and has continued to get worse. This goes up to 10, 11, 12 to 2013. And so certainly we're not getting better outcomes at the life expectancy level. Not better outcomes across many countries in terms of life expectancy. The United States has lower life expectancy compared to other countries in the Western developed capitalist democracies. We have far worse maternal mortality, and this is one of the great sins in the United States, that it's not only much worse than other countries, but we are the only country where it's going up. Um, it's not rationing. One of the arguments you often hear is, oh, well, if you do this, there'll have to be rationing. No, we already have rationing by the ability to pay in the United States, as well as maldistribution by geography. Other countries actually have more hospital inpatient days per capita, so they have more hospital care than we do. Other countries, it's not rationing. Other countries have more ambulatory care visits than we do, have more physician visits per capita than we do. So again, they're providing more inpatient care, more outpatient care overall than we are. The United States, using the same survey method and questions across different countries, the United States reports more self-rationing of patients skipping a consultation, test, treatment, drugs, getting drugs or follow-up care due to costs in the past 12 months, far higher in the United States than in other countries. And I would point out that the country with the most privatized, number two after us, is Switzerland. And lo and behold, they are closest, number two, in terms of that rationing, a self-rationing of care due to cost. It's not due to less need for care. Other countries actually have higher elderly. Because of our immigration, we have a lower average age. We have a lower percentage of our population over the age of 64 than other countries do. So it's not that we have less need for care if they have an older population, and we know older population needs more health care and more expensive health care. Other countries, for example, have much higher smoking rates than we do. One of the public health successes in the United States relative to many other countries. I will say we have higher obesity, but they have higher smoking and certainly higher average age. Total hospital beds per 1,000 population. We saw the patient days in hospitals. United States has less than average number of hospital beds per capita. We're not the bottom, but we're at the lower end. Comparable, I would suggest, roughly comparable to Canada, which has had massive cutbacks with increasingly conservative governments in their provinces in recent years, but certainly far less than in most of Western Europe. Again, I would suggest that the UK is an interesting outlier in the opposite direction of actually spending way too little since they nationalized in 1947-48. So we have less hospital beds per capita than the average amongst Western developed countries, and certainly less than most of Western Europe. And if you look at the employees in hospitals, we have less healthcare staff. If you look at all hospital employment on the left in the dark blue, compared to the next column over of hospital healthcare staff, that is hospital staff actually providing healthcare services compared to hospital employed people doing administration, we have less hospital staff providing health care, 11.2, compared to administrators, 9.9, compared to other countries. And that's employment in hospitals by type of worker per thousand population. Again, never have so many administered, so few providing more and more burdensome overhead on care. Comparative healthcare system performance by a overall scoring system here shows the United States is by far the worst amongst these countries. This is a 10-country average published regularly by the Commonwealth Fund. Now, this is a fascinating study. This is the age-specific mortality rates across 17 peer countries. So again, this is developed, rich, industrialized, capitalist countries, including, by the way, Japan, amongst the 17, as well as Western Europe and Australia. And what you see here is that we rank pretty much dead last in age group specific mortality rates up until the age of 65. We're either 17th, or I guess occasionally 16th. And in one case, we just begin to break out of being at the very, very bottom as you approach age 65. Now, what happens at age 65? Well, one thing that happens, as we know, is that Medicare, as is in the United States, eligibility kicks in. And all of a sudden, the United States performance with Medicare kicking in for the age group specific mortality rate, all of a sudden our performance goes from dead last to increasingly number one, but only after Medicare as is kicks in compared to these other countries. Gee, what if we had expanded and improved Medicare for all going all the way down to age 0? So lots of studies have shown the excess number of deaths due to uninsured and underinsured. My favorite one here is the low end of 18,000 and 6%. That was done by a conservative group, trying to debunk the high-end studies. And try as they might, and they openly said this, our goal was, as conservatives, to debunk the other studies, and what they showed was, well, it's only a 6% higher mortality rate. It's only 18,000 more people dying per year. Again, those excess deaths are cumulative over time, and so we have as many as 500,000 excess deaths. And needless to say, they are not equally distributed by race or ethnicity. They are indeed higher, as you might expect, for African Americans, Latinx, and Native Americans. We have multiple studies that show on average a savings with single payer of about 5.7% on average. Again, the references are all there. Where do those savings come from? Well, we saw before the savings come from the reduced insurance administrative costs. That's the insurance overhead, administration, profiteering, marketing, etc. There's the reduced costs for the physicians and hospitals from their end of administering the billing and so on and so forth. If everybody's just paid, there's no unpaid bills. If everybody's just covered, there's no unpaid bills, and the billing is easy. It just goes to one payer. Hence single payer. And there's the reduced cost of prices across the board, drugs, devices, saline bags, the famous $500 saline bags, and so on and so forth, for a savings of 17.7% in this example. There's the increased cost of covering everybody. There's the increased cost of eliminating the cost sharing. No more deductibles, no more copays. There's actually an improvement in provider fees, we'll come to that, and there's adding in long-term care. That's the home health care and nursing care. And despite all of those improvements, there is still a net savings of 3.6%. And you might say, oh, well, you're an advocate. I don't believe those numbers. Well, those numbers actually come from a center-right group called the RAND Corporation. Look it up. By anybody's evaluation, you'd have to call them a center to center right group that was deliberately brought in to do the conservative estimate for the New York Health Act. A previous economist that was considered a progressive from the University of Massachusetts had also done it and showed a slightly higher net savings. Basically, if you're using honest data, there's a relatively limited range of confidence intervals around any of the inputs and outputs that you can come up with. So this was an analysis that was done by a different group at the University of Massachusetts, for the Sanders National Plan, and I just use it to show you coming up with roughly the same thing. About 12% increase in costs because you're providing more universal health care without copays or deductibles, plus long-term care, but the savings are far greater. Current plan, about $3.24 trillion being spent. If you were to put in a very strong public option where people can buy into Medicare earlier, but you leave in place the private insurance plans, the fragmented system, the limited ability to negotiate from a position of monopoly of the drug costs, you improve probably to about 95% coverage, although you still have the problem of higher costs than people can actually afford in terms of the premiums, copays, deductibles, and out-of-pocket costs that still exist. And you have a massive increase in the total system-wide costs. With single payer, you actually reduce the total system costs, have true universal coverage. How do you do it? Well, one of the ways we are doing it, and we need to admit this, is that a lot of those administrative savings are lost jobs. All of those people selling insurance, all of those people at the insurance companies doing pre-authorization and denial of care, all of those billing people on both sides, many of the billing people, not all, but most of the billing people on both the insurance side and the hospital and doctor's office side, a lot of the savings are them losing their jobs. All single payer bills have a multi-year just transition of actual wage replacement, not just some vague sense of job training, but actual wage replacement. And frankly, the number of jobs that's involved here, although it's very expensive for the healthcare system, is a tiny fraction of the total job churn that exists in the U.S. economy all the time. We're talking somewhere in the range of 2 to 5% of the one-time blip in the total job change churn that happens every year in the United States as people are hired and fired or leave. Current system, the way we pay for it, the other secret in addition to cost savings is cost shifting. And the higher income pays a higher marginal percent through higher taxes rather than the current system, which is a regressive tax where everybody pays the same premium, and sick people, once you get sick, then you have your copays out of network and deductibles, and Jeff Bezos is paying the same as you, is paying the same as one of your patients. This is an example that's very nicely shows the difference. I've got several others, but basically what you see here is at the bottom end of not Medicaid, so below 139% on Medicaid, so not relevant, but between Medicaid and twice the federal poverty level, which is a very low income, we're talking $16,500 to $24,000. What we see here is under the current system, 8.4% of folks are paying, 8.4% of poor people's income is going to healthcare, and only 1.6%, I'm sorry, only 2.6% out here of the high income people are 2%, 2.6% of their income is going to healthcare. So higher percentage of income for lower income people who have less disposable income, lower percentage for higher income people who have higher disposable income. In other words, after they've paid for housing and shelter and food. Um, if you put in the public option system, it shifts the curve down a little bit, but it doesn't really change the shape. Single payer flips the curve so that low income people are paying a lower percentage of their income to health care, and high income people are paying a higher percentage. So cost savings with single payer, net total system cost savings, and cost shifting. What this shows is basically somewhere in the range of the top 5% of income above $460,000 begins to pay more, and the other 95% of people pay less. And this holds true roughly 92 to 98%, depending on the details of the funding. This is how the graduated system works for the New York Health Act. Would point out that current Medicare folks have to pay for deductibles and copays for coinsurance, premiums, many things, including dental, hearing, vision, and long-term care, are not paid for, and drug coverage is incompletely paid for with donut holes and Medigaps. And so, on average, folks are paying, if you're on Medicare, you're paying $6,100 out of pocket, and under single payer, including the New York Health Act, you wouldn't pay anything. The part of that cost shifting is that lower levels of government also save money. So this is an example from the New York Health Act in terms of within New York State, cities and county levels would pay less, and the same applies for national single payer in terms of state paying. Basically, there's a cost savings because the state and county don't have to pay their Medicaid share because that's covered. There's a cost savings for counties, state counties, and municipalities in not the state if it was state-based single payer as employers. So as an employer, cities and counties are paying for teachers and police and other public employees for both their employee health benefit and the retiree health care benefit. And that goes away with single payer. And they're also paying for their public hospitals, both the cost of the public hospital itself, as well as the charity care, the unreimbursed care that's being provided. So this is an example that was done by the Albany County Treasurer, I'm sorry, the City of Albany Treasurer, for the City of Albany, the Albany School District, and Albany County, of what the savings would be for Albany as a jurisdiction if the New York Health Act was passed. This basically amounts to the real estate taxes, the property taxes going way down. Basically, on average, the property taxes in New York State could be cut in half with the, well, about half is going to the property tax, is going to Medicaid, and there would be additional savings in terms of the public employees now being covered at the state level. That could be put back as tax savings or more money into other things that people might want, like education. So the big lie is that it's too expensive. Cost too much is a misdirection where they would say, oh, it's going to cost too much. Well, yeah, the federal government budget goes up in national single payer, or the New York state budget goes up in the case of the New York Health Act because it's the single payer. But it ignores the total system reduction in costs. It ignores the fact that 92 to 98% of households are paying less, as well as any of the employers that are currently providing any support for their employees are saving $9,000 per employee, according to a 2013 calculation. A lower costs for the lower levels of government, Net increase in jobs, by the way. So although a loss of jobs in the administrative bureaucratic overhead of insurance, there is a stimulus of everybody having guaranteed health care regardless of their status, as well as the savings to the employers that creates a net increase. So it's a net cost savings and a cost shifting to those who can afford it. I'm going to hurry up here. My apologies for running a little over. The rising support in single payer. Again, this is AP Reuters. This is Economist YouGov showing strong support, over 60% support amongst all voters, up to as high as 80% amongst Democrats, and even 50-50 on amongst Republicans. This is when you make it independent of, a specific campaign or candidate. Why is it good for doctors? Well, this is a series that's been done every year for many years by the Commonwealth Fund and the OECD, looking at looking at physician satisfaction, primary care doctor satisfaction with their practice, and the U.S. is always second to lowest. There is something going on in Germany, and I don't know what it is, but the U.S. is always the second lowest and significantly lower than other countries. This is the amount of time spent on administrative overhead versus patient care. In the United States, about 26% of primary care physicians about 26% of the time is spent on patient care compared to 65% in Canada. Fascinating study. This was in Annals of Internal Medicine, your journal. This looked at how many keystrokes are inputted in an average ambulatory care note in Epic. So it turns out that Epic is used in other countries as well. And this is the average, this is the distribution curve for the number of keystrokes across 15 or 17 different institutions in the United States. 16 different institutions in the United States compared to 16 other countries where they collected the data. This is the average number of keystrokes distribution amongst primary care practitioners in those institutions. In red is the distribution for the United States, and in the teal is the distribution in 13 other countries. Notice the complete lack of overlap. Far less keystrokes per Epic EHR note for primary care in these 13 other countries. 3/4 of our charting is not for healthcare. 3/4 of our charting is for billing and insurance. So even our EHRs get a lot better. We spend a lot of our time and money managing insurance companies. If you're a primary care doctor practice, you're spending, as we saw before, several multiples of your cost of your practice interacting with insurance companies. Canadian physicians' income is just fine. Thank you very much. This was average clinical payment. So this is income due to clinical payments, not other sources, for physicians in Canada. The averages compare quite nicely to the United States. And let's remember this is an average, so it's including the newbies just out of residency and the old timers. And let's remember, this is gross. And as we've seen already, they have a much lower overhead between the administrative costs and, quite frankly, their also their malpractice coverage costs being lower. So their net is greater. There's always this fear that somehow the doctors will make less money under single payer. So these are 3 recent estimates by single payer opponents. Let me make that clear. These are analyses that were done around the time of peak interest in single payer during the Bernie 2016 campaign by the Mercatus Institute, which is a far-right group funded by the Koch brothers, the Rand Corporation, which is a center-right organization, and the Urban Institute, which is a ostensibly progressive liberal group, but which amongst those is the ones most institutionally opposed to single payer, which probably has something to do with their funders. So, but is nominally a Democratic aligned sort of centrist neoliberal group. And what you see here is in all of them, they acknowledge that under single payer, more total dollars would be going to doctors, total payments going to doctors, plus lower overhead. Do the math. Physicians moving to Canada? Well, actually, it's the other way around. American physicians are increasingly moving to Canada, not Canadian physicians moving to the US. Here we see the net migration is actually going to Canada, not the United States. Some quotes from the head of the American Academy of Family Practice about the bureaucratic mess of practicing in the US compared to Canada. We have two surveys, sources for doctors supporting single payer overall. This is from Merritt Hawkins, which is a organization that does HR, human resources, physician recruiting and placement services, for-profit company, doing surveys as part of their, general practice of seeing of opinions amongst physicians, going from 58% opposition in 2008 to 56% support in 2017. Dr. Carol and Ackerman have published two studies in 2003 and again in 2008 using the AMA data set. This is not AMA members. This is all doctors. The AMA has a separate role, federally supported to keep a tab of all doctors registered in the United States through licensing and NPI, showing a move again from 49% in support, according to their survey in 2002. This is peer review. This is an appropriately distributed sample by specialty and geographic distribution, etc., to 59% in favor, which is interesting, a 10% gain over 6 years. There is a wide range of differences by specialty, as you might expect, and also by region in terms of the two coasts compared to the center or south of America, the United States, urban and rural, all the usual distribution differences you would expect. Organized medicine is tipping. Your own American College of Physicians announced only two roads forward, either Medicare for all or a strong public option. Society of General Internal Medicine endorsed single payer specifically. The AMA, a very conservative organization with under 20% of physicians as paid members, who are the only ones that are allowed to participate in the voting, had 47% support in their House of Delegates in 2019. American College of Surgeons, the most conservative group, had their president testifying in favor of single payer and felt that managed competition, which is what we've wound up with more and more of, was going to be a disaster for professional autonomy and income. We've seen with single payer, we've seen with COVID that it's the current system that makes it more inhospitable for hospitals. I know I'm out of time, so I'm going to just acknowledge I have a separate talk on how hospitals actually would benefit under single payer than they would under the current system of private insurance working on deny, delay, and reduce, and demand having to have elective surgery be what pays for the profit of hospitals. And again, the same three groups looking at payments to hospitals under single payer would actually increase, even conservative anti-single payer groups acknowledging this. And I will stop here. My apologies for running over. Well, let me just make what are the arguments against single payer. So the argument against single payer, as I see it, there is no real pure policy argument in terms of the economics if your goal is to cover everybody, save money, and distribute how it's paid for progressively. The argument against it is essentially a political argument, that it will never happen, and therefore it's not worth fighting for it, and we should put all of our energy expenditure into fighting for the best that we can get. We've seen that fight in the Build Back Better politics of recent months. And what I would say is let's do both. Single payer movement backed Build Back Better, backed the expanded and improved slightly expanded, slightly improved, slightly better Medicare for slightly more people under the current plan. And I will stop there.